Be able to discuss these important and very intriguing clinical trials, which really illustrate why we need to do clinical trials to challenge the status quo and to test our hypotheses. Here are my disclosures. So clinical trials of cardiac myosin inhibitors versus placebo have been highly successful for obstructive HCM. We've had phase 3 trials using mavacamten and aficamten, which have been positive, showing improvement in feel and function as reflected by improving peak VO2 and NYHA class, as well as deferral of invasive septal reduction therapy. Patient-reported outcomes, NT-proBNP, and diastolic parameters have also improved. And in this way, cardiac myosin inhibitors are really changing our practice in HCM. They're the first disease-specific therapy that have been developed. They've been developed based on mechanistic insights and improved understanding of the pathobiology of HCM, and they finally provide evidence from randomized clinical trials to guide our management. And indeed, both the European and the American management guidelines have been recently updated to suggest adding cardiac myosin inhibitors after trying beta blockers or calcium channel blockers if patients have refractory symptoms. And we finally have robust levels of evidence, again guided by randomized clinical trials to support our practice. And so MAPLE HCM really helps us to challenge our status quo by questioning the efficacy of our historic traditional first-line therapy of beta blockers. You know, how good is our traditional therapy? And so here we can see that effects of MAPLE HCM of aficamten versus metoprolol versus Sequoia, which is the randomized trial of aficamten versus placebo. In MAPLE, the improvement of peak VO2, while clinically significant and clinically meaningful, was actually slightly less than the improvement that we saw in Sequoia, improvement of 1.1 mils per kg per minute versus 1.8 in Sequoia. But the difference between the comparator groups is larger in MAPLE because our beta blockers, the metoprolol comparator group, actually had a decrease in peak VO2 in MAPLE versus no real change in peak VO2 in placebo versus aficamten in Sequoia. And additionally, as we just heard, there was very minimal impact on obstructive physiology with either beta blocker, metoprolol, or placebo. We see that there was an improvement, a slight improvement in KCCQ score, both with beta blocker and with placebo, and it's a good illustration of the impact of trial participation on subjective metrics of symptom burden and quality of life. So with MAPLE, I think that what we've learned is that we need to beware when our standard of care evolves out of practice rather than out of evidence, and then challenging the status quo is needed for progress in medicine, and that beta blockers may not provide meaningful benefit in our patients with symptomatic obstructive HCM. They may not be as well tolerated as initially believed. And evidence is now available to consider using cardiac myosin inhibitors as first-line therapy in symptomatic obstructive HCM, but practical, pragmatic implementation of this practice will probably require easier initiation and maintenance of cardiac myosin inhibitor therapy, and of course payer support to make sure that it's affordable for our patients. And then switching gears to the Odyssey HCM trial. So this trial was testing the rationale for using cardiac myosin inhibitors in non-obstructive HCM, an area where we have great unmet need. And this is based on the putative mechanism of symptoms in non-obstructive HCM, thinking that diastolic abnormalities and inefficient myocardial energetics are drivers of symptoms. And there are theoretical reasons to believe that CMIs may be beneficial for this. As we've heard, there are secondary findings and ancillary studies in obstructive HCM has shown that cardiac myosin inhibitors decrease NT-proBNP, decrease left atrial size, improve E prime velocity and E over E prime ratio. We know that in HCM, that there is a destabilization of the most relaxed or super relaxed form of cardiac myosin, and an increase in the amount of disordered relaxed myosin at the expense of 5 times greater energy utilization of disordered relaxed state versus super relaxed state, and that the super relaxed state in vitro and preclinical models is stabilized by mavacamten. And in phase 2 trials of non-obstructive HCM, we've seen improvements in NT-proBNP values with mavacamten versus placebo. But with the Odyssey trials, mavacamten performed differently than how we have seen it perform with obstructive HCM. So you can see that in Odyssey with non-obstructive HCM, there was a very slight and not clinically significant or statistically significant improvement in the peak VO2. But if we look here at in this figure adapted from the Explorer trial and using mavacamten with obstructive HCM, you can see that there is a clinically and statistically significant improvement in peak VO2 of 1.4, which is generally the range that we've seen peak VO2 improve in obstructive HCM. And although no significant improvement was seen in KCCQ in non-obstructive HCM, the KCCQ scores typically improve quite substantially in obstructive HCM with an improvement of 9 points in Explorer, and that's much higher than what is typically seen with medical therapy. And also, we wonder whether mavacamten actually hit the target in non-obstructive HCM versus obstructive HCM by looking at the NT-proBNP values. So, although NT-proBNP values have consistently decreased dramatically with CMI use in obstructive HCM, and we saw significant reduction of NT-proBNP in the phase 2 MAVERICK trial in non-obstructive HCM, in Odyssey, we do not see a substantial decrease in NT-proBNP levels in non-obstructive HCM, and that leads us to question the hemodynamic benefit of the therapy that was seen. And also, in the absence of a clearly significant benefit, there are questions that are raised about the tolerance and dosing in non-obstructive HCM. Are cardiac myosin inhibitors as well tolerated in non-obstructive versus obstructive HCM? There was a much higher proportion of patients in the non-obstructive Odyssey trial that experienced a decrease in LVEF, heart failure, and who withdrew from therapy. So looking at Odyssey HCM with non-obstructive patients, you can see that over 20% had a decrease in LVEF, less than 50%, compared to just under 4% in Explorer with obstructive HCM. And then we also saw much more dramatic excursions of EF, less than 30% and 2% of Odyssey, and this was not seen in the Explorer trial. Heart failure events were much higher, 7% versus 2%, and a substantially higher proportion of patients withdrew from therapy or discontinued therapy. And I think that this all loops back to whether we know the right dose for treating patients with non-obstructive HCM. In Odyssey, the titrations were really based on preserving left ventricular ejection fraction rather than reducing gradient. So our target dose in non-obstructive HCM is based on the maximally tolerated dose. Titration was indicated by protocol if the LVEF was over 65%. But in obstructive HCM, we have a much more direct target of gradient reduction, and therefore we can choose the minimally effective dose which is able to resolve obstruction. So is there a future for CMIs in non-obstructive HCM? Well, I think so, but we need to learn a lot more about cardiac myosin inhibitors in this population and also about non-obstructive HCM in general. So obstructive HCM is relatively straightforward. If we improve obstruction and reduce gradient, there's clinical improvement. But non-obstructive HCM is much more complex and heterogeneous. A one-size-fits-all approach to therapy is unlikely to be successful. So can we identify physiologically relevant subgroups who will benefit from cardiac myosin inhibitors within the larger, broader, non-obstructive HCM cohort. Are there hyperdynamic patients that may benefit? Notably in Explorer, with obstructive HCM, the mean ejection fraction was 74%. In Odyssey, the mean baseline ejection fraction was 66%. But are there patients on the higher end of the EF scale that might benefit? And what about patients with mid-cavity obstruction? So again, a marker of hyperdynamic physiology. Would those patients maybe specifically benefit from cardiac myosin inhibition? We need to be better about understanding what drives symptoms in non-obstructive HCM. Do our CMIs actually improve relaxation and energetics at a pharmacologic dose, if that's really what's behind symptoms? Or is their benefit predominantly due to relief of LV alpha tract obstruction? And finally, stay tuned. More information will be coming shortly. Hopefully we'll see some very robust responder analyses in Odyssey HCM to help us break down who may have received benefit and why. And also the Acacia HCM trial is in progress. So this is using aficamten versus placebo, also in symptomatic non-obstructive HCM patients. And the top line results are expected early in 2026. Thank you very much.